Okay, good afternoon, everyone. On behalf of the President of Taiwan Oncology Nursing Society, I would like to welcome you all to attend the third Asia Pacific Cholangiocarcinoma Conference. First of all, I would like to thank for a number of internationally well-known scholars from USA and Taiwan to share their knowledge and expertise, especially in the area of oncology nursing care. Secondly, I also would like to thank for the conference committee to make the conference possible. Of course, your active participation is very appreciated. And I hope that you will enjoy today's program. The first session for this afternoon's program is presented by Dr. Susan Acquisto. Dr. Acquisto received her doctorate degree of nursing practice, healthcare executive leadership from University of San Francisco in the USA. And also she is the president and the CEO of a healthcare consulting, regulatory risk compliance specialist incorporation, and also a co-founder of the BioProject Foundation devoted to funding a number of multidisciplinary research projects for bile duct, gallbladder, and liver cancers. And today she is going to share with us about an international collaborative of cancer, clinical research, clinical nursing practice, evidence-based guidelines for caring patients with cholangiocarcinoma. Let's welcome her, Dr. Susan.
Thank you, Zui. It's a pleasure to be here and an honor before you to share our work with you. And in an interest of time, I have 15 minutes to share a lot of work, so we'll go ahead and just get started quickly. As we know, researchers state that cholangiocarcinoma is a multifactorial disease process. And there's been definitive risk factors, as we all have heard, especially this morning. And the risk factors such as hepatitis B, virus, cirrhosis, obesity, and smoking have also been linked to the development of cholangiocarcinoma, but of course more research is needed. And Bridgewater in 2014 conducted, according to the SEER data, reported that there was an increase of incidence of diabetes with intrahepatic cholangiocarcinoma, as well as obesity has been linked to cholangiocarcinoma. And what's been most noted that there's 90% of individuals diagnosed with cholangiocarcinoma in the Western countries. We've had no defined risk factors. The symptoms associated with cholangiocarcinoma are unfortunately often nonspecific, which leads to the late diagnosis in the majority of cases. And when symptoms do occur, it's late in the disease process, typically dependent on the anatomic location of the tumor, with extrahepatic tumors presenting jaundice, painless jaundice, more so than the intrahepatic tumors. And individuals with the late-stage intrahepatic cholangiocarcinoma experience the recurrent fevers, night sweats, weight loss, pain, and nausea, and a palpable abdominal mass. Treatments for cholangiocarcinoma are heavily dependent on the stage and resectability of this tumor. And the current standard of care is to attempt resection on the patients, as a lot of discussion this morning has talked about. The gemcitabine and cisplatin systemic therapy is our standard of care, and other therapies such as liver transplant are controversial. The effects and impact of cholangiocarcinoma on health. The physical impact of cholangiocarcinoma is undeniable, with the mortality rate for both the intrahepatic and the extrahepatic cholangiocarcinoma still being very high, even with the systemic therapy and surgical resection. The physical suffering during the illness due to the pain, nausea, and pruritus should be taken into account. And it impacts the mental health as well of the family and the individual due to the high mortality rate and the pain that they experience of this disease. Public health interventions and the tertiary prevention in the form of these therapies such as surgical resection or biliary stenting to relieve the obstruction. And then there's primary prevention such as the Loya project in northern Thailand, which focused on educating the community on the liver fluke cycle, changes in dietary and the sanitary practices. And then there's also tertiary prevention in the form of support of these individuals and families affected by this. The tertiary prevention also reduces, what we aim to do is reduce the disease impact. The surgical resection to remove the tumor, to either cure or improve the quality of life. The palliative stenting to relieve the obstruction. Systemic chemotherapy, the standard of care gemcitabine. Pharmacotherapeutics that control either the pain or antiemetics, and other therapies reducing the tumor bulk, such as TACE, RFA, or radiation. So with this led our group. We have a nursing advisory board of the Cholangiocarcinoma Foundation. So what you've just heard, knowing that in the current state of current knowledge that we know about cholangiocarcinoma. So what our aim was is that we took an interdisciplinary team of nursing bench practice nurses from around our country at the major cancer centers. You'll see there we have Lorraine Drapik, who's one of our speakers today. She's our co-chair of the committee. From Massachusetts General, we have Dr. Renuka Iyer, who's also speaking today. She's our medical advisor. And so you see here we have some MD Anderson. We have Elizabeth Bradley from Queen Elizabeth Hospital. Laura from Carolina Medical Center. We have Mayo Clinic represented. We have Regional Medical Center in Orange, Roswell Park Center, Mayo Clinic in Jacksonville, and we have a patient who's also a patient advocate. So we really tried to get an interdisciplinary approach to our Nursing Advisory Board, because really our mission, the mission of the Nursing Advisory Board was to advance the scientific knowledge of nurses, because we wanted to be able to have nursing be able to competently and confidently care for these patients. So to improve the scientific knowledge of the symptom experience that we just discussed briefly, their quality of life with the treatments and symptoms that they experience, and also to develop something that would have a springboard for further research, for additional guidelines. We wanted this to be an international, multi-institutional collaboration and a multidisciplinary collaboration. We always are looking for additional members to our Nursing Advisory Board. So any of our distinguished faculty or nurses present here are always welcome to be part of our board, and we welcome that. Our methodology was we wanted, as I was stating earlier, to assess the current state of knowledge. So as with any assessment, right, you're going to go to all of the databases. And here we did an extensive search of PubMed, Midline, Sinal, Up to Date, and a book that we referenced. But actually what we did is we referenced over 100 articles and books to be able to develop the guidelines. And so our model was, in order for the signs and symptoms that I just had reviewed with you, we took a review of the patient registry. The Cholangiocarcinoma Foundation has a patient registry in which patients report their signs and symptoms that they are experiencing. We also have our distinguished medical advisor, Dr. Iyer, who had the results of a multi-center phase 2 study of a gemcitabine capecitabine investment for the advanced metastatic adenocarcinoma, the gallbladder and biliary ducts. Trying to say that fast. With this study, she gave us the data on the side effects that these patients were experiencing, because not only do we have the symptoms of the disease, but we're having the side effects of the treatment, right? So our aim then was into taking our expertise of the Nursing Advisory Board. So we didn't really outline the expertise, but we have everything from radiation oncology, medical oncology, liver transplant, the various specialties of these nurses from the various cancer centers represented on the board. So we took that expertise, and our model then was to outline what assessment findings you would have with the interventions, the references of the 100 plus that I mentioned to you, and then we took an evidence-based rating from the Johns Hopkins University to rate our literature. And then, of course, results. So real quick, on here, so really kind of the formula, if you will, is our systematic review of the literature. Whatever we couldn't find from the literature, we did institutional practice. So of the best institutions that we had on our board, right, we took what that practice was along with the systematic review. We had a consensus, and we then presented to the medical advisory board. And just for their review and approval for additional evidence-based. The Johns Hopkins evidence-based rating scale, as you see here, there's levels 1 through 5, right? And so level 1 would be the randomized controlled trial. Then you have your quasi-experimental study, and then you have, so I can see here, then a non-experimental study. Then level 4, which is what we found a lot in our literature search, was because we didn't have a lot of this in nursing for us to establish our guidelines, we went with a lot of the opinions of nationally recognized experts. For us, like the NCCN and that have published guidelines, we took the information from that because those were the experts. And then level 5 is the opinion of an individual expert. Based on their literature review, a quality improvement, or clinical expertise. And so that is the first level of rating. Then the second part to this is then of that level. So if it's a randomized controlled trial or an expert panel, was their level of research, the quality of their evidence, was it a consistent results with sufficient sample size? Was there summative reviews? Was it a well-defined search? The organizational, was it well-defined methods? So when we were looking at the literature, and it goes all the way, you have high, good, or low quality. Now, we're certainly not going to take literature from the low quality. So if we found an article or any literature that was in the low quality, we did not use that. We did mostly in the high and in good, so that we had good, consistent results. It was valid and reliable. So this became very important as we determined which articles we were going to reference for our guidelines, for the assessments interventions. So we then established clinical nursing practice guidelines. And of the guidelines that we have developed so far, you'll see, because this was based on, and you see the intractable nausea and vomiting, from the studies, from Dr. Iyer's study, from the patient registry, these patients predominantly experience intractable nausea and vomiting. The extraordinary fatigue that comes with this disease. Then they also oftentimes have biliary drains and stents. The gem cyst, receiving photon radiation. We have protons on a clinical trial. Those patients carrying a liver transplantation. Those patients with ineffective coping and mindfulness. Right? This is so important for these patients because they also, as a part of the tumor progression, experience a severe depression. Right? And so that was we found that was very important in their ineffective coping. And then care, our most recent guideline is care of the patient with cholangitis. Current ones that we have under review, under development, is they also experience a lot of itching, right? What's the evidence support of caring for those patients? How do we intervene? Obviously with physician's orders, but how do we intervene with the patients with the itching there? The nutrition management, we find that the nutrition is so important with these patients in helping with their energy and their ability to have the treatment be most efficacious. And then palliative care. We've had a lot of discussions around palliative care for these patients with cholangiocarcinoma. So this is an example of one with the biliary stents, and this is how we modeled it so that with nursing practice, goals and objectives. So we had our category, you have your guideline content. And so this was the goal. We start off with goals of what the patient would do with that particular guideline. So obviously, the patient or family will be able to describe their disease and disease process. They'll be able to describe the signs and symptoms of the disease with the treatment with the biliary stents to monitor for and report to the clinical team. Patients and their family will have a working knowledge of caring for the biliary drainage system. They'll be able to list the common side effects, and they'll be able to list the measurements to prevent and manage side effects of the biliary drainage catheter. So those were overall goals that we established for these patients. So then, the next category then is assessment. And as you'll see here, when we get to the intervention, for each assessment finding, we had an intervention. And on the assessment here, for instance, document the onset and presence of symptoms of jaundice, pale stool, dark urine, pruritus, abdominal pain, fever, weight loss, the fatigue, all the symptoms I've just talked about, right? And so documents, so we're assessing, those patients are going to usually come to us, and we're documenting that. We would expect to find in our assessment these signs and symptoms. And this here, you see the 2 and the 3, T2 4A and 3 4A. Each assessment and each intervention had the evidence-based rating. And the 2, when you'll see in the last slide, is the number of their reference. So that was why it was important for us, but we did the guideline to have the goals, the assessments, the interventions, and the references with the guideline, so that as you could see, and as we go forward to update, you'll know which articles or which citation we use for that particular intervention and assessment. So this is reference number 2. It had a rating of 4A. So remember, 4 was the national consensus, right, an expert panel, and A was high level, right? So most of it, we really tried to get the highest level of evidence rating that we could. Obviously, random control trial is, level 1, but as we were saying, we didn't find that much in the nursing literature. So really what we want is our goal and mission to have these as your springboard for further research, right? That you test our theory, you test our guideline. Is it effective? Can you find a better intervention? And we welcome that. And like for instance, the second, you're going to be looking at the labs, right? As you're looking at the lab work, what are you expecting to find? You're going to find the CBCs, the PT time, the bilirubin, right? The liver enzymes, the alkaline phosphatase, the imaging, right? The ultrasound, the CTs, all of these diagnostics. Certainly you're not ordering them, but you're going to be, as you're assessing these patients, you're looking at these diagnostics in the lab and the diagnostics. There again, and for reference, you'll find 2, which is the second listed reference, 4A, 3, 4A. So the highest level of evidence that we could find. Continuing on with assessment, identify via the physician documentation. And this helps you guide with what kinds of questions are you going to ask the physician. If it's not readily documented in the medical record, at least you know the question to ask around the external biliary drainage, right? Whether it's external biliary drainage, whether it's an external biliary drainage catheter, internal biliary drainage is stenting, is it a metal or is it a plastic, right? Because as we well know, the plastic stents don't last as long as the metal, right? And there's oftentimes, as we find in the literature, more complications with infections with the plastic stents. But they're using the plastic stents for a more shorter time frame with the expectation to hopefully have surgery. They're not going to put those in. And it's important for you to know around the metal stents because they have a life too, right? They have a life of about, 6 months, 6 or 7 months. And if you know that, if you have a patient coming in with signs and symptoms of cholangitis and you know they've got a stent, that's going to cue you in to reporting the signs and symptoms more effectively to the physicians, right? That's what this is all about, is to be able to critically think, be able to know what the assessment findings you expect to find, and know what the interventions are going to be. Now the interventions, well, for each assessment finding, as we'd said earlier, you have an intervention with each assessment. And so remember we talked about the signs and symptoms of the jaundice, right? The pale urine, the dark urine and the pale stool. Confirm with the physician if the jaundice is caused by bile duct obstruction. Note the differential diagnosis, which includes non-obstructive jaundice, such as either diffuse hepatocellular disease, such as cirrhosis, hepatitis, and widespread metastatic disease, or hemolytic anemia, metabolic deficiency. If you've got a brand new patient coming in and you're looking at diagnosis, right, they're trying to diagnose what the patient has, you're going to also consider these other things as well, right, in your assessment and being able to report your findings to the physician. When we talked about the biliary drainage, right, the intervention, the routine biliary drainage before assessing resectability should be avoided. This just talks about, you know, what the kinds of things that you're going to expect before resection, the kinds of external biliary drainage. What are you going to observe? You're going to observe the drainage from the catheter attached to the drainage bag. It talks about the internal external biliary drainage. One end of the catheter sits in the small intestine, the other comes out the patient's body attached to a drainage bag. And then the internal biliary drainage catheter is removed within 24 hours of a stent successful. So, and then there's also care of the biliary drainage catheter. You know, typically you're going to see 400 to 1,000 cc's of bile-colored drainage daily into the drainage bag. So here, these are interventions in the sense that, yes, you're assessing, but you're going to expect this in your interventions around the biliary drainage and the care of the biliary drainage bag. We continue on with addressing the stopcock, the drainage bag, when that should be changed, advising the patients that the fluid should not change color or consistency. Teach them to inspect their catheter and drainage bag. So for those patients that go home with their drainage catheters, what are you going to be teaching as an intervention? What's your patient teaching? Patients should be instructed to contact their clinical team or seek medical attention if they experience fever, shaking chills, or increased jaundice, right? There is your typical symptoms of cholangitis. And then again, interventions, this is to help teach your patients, avoiding movements that involve aggressive stretching from side to side, do not swim with the catheter, and patients can take showers with proper covering of catheter site. So I'm not going to read the whole slide to you, but you see after each intervention, you've got your rating, right? So on this one, this is the number 1 reference, this was a 5A. Number 2 reference, this was a 4A. Some of the interventions we had from more than 1 reference, right, from the highest level of evidence that we could find. So you see here then, in our references, they're all numbered so that you can go back and see exactly where this comes from, where the assessment and interventions come from. It's really just a model, if you will, that helps you know exactly where we got that assessment and intervention information, the springboard for further research, further development of additional guidelines, and again, like I said earlier, to test the efficacy. We have, this will be difficult for you to read, but this was our poster. We do have a poster in the poster session there on this collaboration for the guidelines. We have presented this at the European Oncology Nursing Society, as well as ASCO, American Society of Clinical Oncology, ASTRO, the International Transplant Nurses Society, and so we have also been published in the Clinical Journal of Oncology Nursing as well. So as we continue our development of the guidelines, this will be additional information for further research. I'd like to acknowledge Dr. Iyer for her invaluable help as our medical advisor on this board, our nursing advisory board, and our medical advisory board, as a real, truly collaborative effort between physicians, nursing, and the interdisciplinary team. And thank you. I think, did I meet my time limit?
Never mind. Once again, thank you so much. It's such comprehensive and remarkable multidisciplinary work. Really appreciate your presentation.
Thank you.